Good evening, everyone. It's a pleasure to have you all join us today for the second CPD event of this month, organized by the Sri Lanka College of Specialist Family Physicians. As we begin, I'd like to remind everyone of a few housekeeping rules. Please ensure that your Zoom display name matches the name you would like on your participation certificate. Toward the end of the lecture, we'll share a link in the chat for a feedback form. Completing this form and attending the lecture for a minimum of 45 minutes are required to receive your certificate. The feedback form will include 3 multiple choice questions. Please select the correct answers using the check boxes. The correct answers and your participation certificate will be emailed to you. If you have any questions, please type them in the chat box. They will be addressed after the lecture. To ensure a smooth session, please keep your microphones muted at all times. So today we have with us Dr. Nimesha Gamhewage, a distinguished consultant neonatologist at Colombo South Teaching Hospital and also a senior lecturer in pediatrics at the University of Sri Jayewardenepura. Dr. Gamhewage has made a significant contribution to the field of pediatrics, both as a skilled clinician and as an academic. So she will be speaking to us today on common neonatal presentations in primary care. Over to you, madam.
Thank you very much for that generous introduction. I hope I'm loud and clear and you can see my set of slides.
Yes, madam.
Okay, so we'll move on. So in the next 1 hour, I'll try to discuss with you about some common problems that we encounter in newborns, and I'm sure you will also encounter them in your general practice. So I will quickly go through the poor weight gain, jaundice, sepsis, and also the newborn examination, where we will be discussing about some of the common conditions that we encounter in the examination and what we need to do for these type of babies. So this is our first scenario where we have a 2-week-old baby brought to you and the mom thinks she's having insufficient breast milk. Trust me, this is one of the commonest presentations that you will get when you are starting your practice. So this is going back to the history. This is a term baby, had uncomplicated antenatal period, uncomplicated vaginal delivery, and the birth weight was 3 kilos. Current weight is 2.5 kilos. And the mother is adamant that she thinks she has poor milk supply and she requests formula from you. And let's see how you will manage this type of a common scenario. Now, first of all, when a patient comes to you with a concern like this, first of all, you need to establish whether this baby is having a normal weight gain or inadequate weight gain. And then only you are going to establish what this mother's concern, whether she's having insufficient breast milk or it's just, baby is not putting on weight just because the problem is with the feeding technique or whether there is any organic pathology in the baby. And you need to then determine what investigations I need to perform in this baby and how I'm going to manage this baby. Now, if you go back to the case, you have a 2-week-old term baby and current weight is 2.5, whereas the birth weight is 3 kilos. So what do you know about the normal weight gain of newborn babies? So they initially tend to lose weight initially, but within the first 7 to 10 days, the weight loss cannot exceed 10% from the birth weight at any given time. Having said that, any newborn is not supposed to lose more than 5% of the birth weight in the first 24 hours of life. Actually, if that is the case, we are not even allowed to discharge the baby from the hospital. So what happens is initially because of the diuresis, they lose the weight. and thereafter they slowly gain the weight if the breastfeeding is established nicely. And around 10 to 14 days of life in a term newborn baby, they reach the birth weight. So this baby at 2 weeks of life, if the baby is healthy and fed well, should have reached the birth weight by this age. But you can see the baby is having a 2.5% weight. So sorry, 500 grams weight loss still. So afterwards, the weight gain is 25. After reaching the birth weight, the weight gain must be 25 to 30 grams per day for the first 3 months of life. In a preterm baby, we can allow slightly a longer period where we can wait until about 3 weeks of age for that preterm baby to reach the birth weight. And also, if the baby is really small, we can't expect the baby to have like 25 to 30 gram weight gain. Therefore, we calculate for the for per kg per day weight gain for that type of small babies. So the expectation is for them to gain 10 to 15 grams per kilo per day. For example, if you are dealing with a 1 kilo baby, the expectation is after reaching the birth weight to gain every day by about 10 to 15 grams. It's unfair for us to expect this small baby to gain like 25 to 30 grams per day. I hope that's clear, right? So now we have clearly established here that there is an issue with the weight gain. So now we are going to look at, okay, what are the common problems associated, what are the causes which could lead to poor weight gain in newborn babies. Now, 99% of the time, the main cause is inefficient, ineffective breastfeeding. And then very small proportion of babies would have organic pathology. So this organic pathology could be inability to retain the milk in the gut or increased energy requirement. So let's take the first instance. So that is inability to retain. So that could be a severe GORD where the baby is having a significant vomiting, maybe even projectile vomiting indicating pyloric stenosis. Okay. So after each feed, the baby is vomiting in significant volumes. Remember, just a bit of, vomiters, which is like regurgitation, coming from the angle of the mouth, we wouldn't consider it as a significant vomiting. But if it happens in significant volumes, more than a palmful, happening each time, affecting the weight gain, we would consider it as a significant GORD or vomiting. The next category is reduced absorption, which is fortunately rare in our country, where there could be a malabsorption, where there is a diarrhea. So the baby is passing constantly very watery liquid stools. Looking at the other pathologies, it's very important to do a head-to-toe examination and also to take a nice history to look at and identify the other pathologies. I'll quickly go through them. One is, of course, urinary tract infection, which would be the commonest organic pathology these babies could be having. So what are the symptoms? They could be crying when they are passing urine. Now, if you ask 100 mothers, does your baby cry while passing urine? They will say yes, but you have to be specific and ask specific question. The specific question to ask is your baby crying while passing urine? Now remember, it's normal for them to cry before passing urine and also after passing urine. If the baby is crying while passing urine, then that's abnormal and that might indicate dysuria, therefore urinary tract infection. Also ask about, hello, yeah.
Yeah, slides are not moving, or is it the same slides?
No, I'm not moving. Yeah.
Right, okay.
Yeah. So the next thing is ask about the urinary flow, especially in baby boys. They should be passing, with a nice flow. And then we know there are no obstructive lesions in the urinary tract. Okay. There could be a mild low-grade fever as well in these babies. The next thing is some genitourinary problems such as, inability to retain electrolytes and water by the kidneys. It could be renal tubular acidosis, it could be Bartter syndrome, or it could be polycystic kidneys, very rare. The next organ to consider is your heart. Whether the baby is having a congenital heart disease, for example, a VSD leading to heart failure. So around 2 weeks, this is very common. This could happen. And also look at have an idea about the central nervous system of the baby, because if the baby is having any neurological disability, abnormality, maybe floppy babies, hypotonic babies, and then these babies, they have an inability to suck milk from the mother, and therefore could be having poor weight gain. So these are the common pathologies which could lead to a poor weight gain in a newborn baby. Now, I told you that 99% of the time it's due to poor breast milk intake. So how are you going to ascertain whether the baby's breastfeeding is adequate? So that's a very easy thing to do. First of all, you need to examine a feed. So there are two things that you are going to assess. First one is the positioning, and the second one is attachment. So in the positioning, there are a couple of positions that the mother can use, but the main thing is the baby's head and body should be supported by the mother. Baby should be held very close to the mother, and baby's face and the body turn to the same side. They can't have like rotated neck and the head is turning to the mother and the body is turned the other way. Those are the main things to look at. And then you have to look at the attachment. This is very important. So if you see just this type of attachment where there is just the nipple sucking, then it's not going to be helpful at all. The baby is not going to get sufficient amount of milk. So ideally the baby's mouth should be wide open and the lower lip is everted outside. The chin is touching the breast, and you can see most of the areola is inside the baby's mouth. So these are features of a good positioning. So that's the very first thing. And next, ask about the feeding of the baby. So generally, babies tend to take a breastfeed for about 20 to 30 minutes, but that's not a must. Some babies are very efficient in sucking. They can even finish a breast within 10 to 15 minutes time. But remember, if they are taking like 45 minutes, 1 hour, that always says that there is an element of poor latch. By the end of the feed, the mother should feel the fullness of the breast is going away, so that you are sure that the baby is taking a good amount of feed. The other thing to look at is the sleeping pattern of the baby. If the baby is satisfied, the baby is going to sleep for 1.5 to 2 hours, or sometimes even 3 hours. So that implies the baby is satisfied, right? If the baby is always crying and asking for feed, that means again insufficient feeding. The next thing to look at is urine output. Now, after the 3rd day of life, baby is supposed to pass at least 6 times urine, which is diluted and in good volumes. First day of life, once is enough. Second day of life, 2 times is enough. Third day of life, 3 times is enough. Afterwards, you need to have at least 6 times, and that's a must. Remember, bowel motion, bowel output or pooping has no relationship with the feeding efficiency. They tend to change the meconium color into the transition stool, which is, the cow dung color around 5-6 days of life. But, even if they open bowels like 10 times a day, that doesn't mean that they are feeding very well. Or if they did not open the bowels for 10 days duration, even you are not going to be bothered if the baby is otherwise okay, right? After that, if there is poor feeding, you can assess the breast milk volume of the mother. So again, something to remember is you are not going to get those full engorged breast and leaking breast during the first week of life. You might have heard about, you have learned about the ejection reflex, where there is, passage of, milk from, while thinking about the baby, and also when the mother is feeding from one side, she gets leaking from the other side. Those things might not be there in the mother in the first week of life. Even afterwards, you are not just going to judge the mother's milk volumes depending on the presence of these reflexes. We know some normal mothers, they never get these reflexes, so that's perfectly normal. So don't go by these reflexes. So what we know is, if we get the mother to do on-demand feeding, that is not going by the 2-hourly or 3-hourly feeds, but giving the feeds whenever the baby requests and shows the hunger cues throughout the day and night, in the correct position and attachment, mother is going to increase her milk supply sufficiently. So those are the main things to look at. And even though all these things are adequately there, some mothers do this funny thing where they tend to give milk from one side for 10 minutes and then change the baby over to the other side for the next 10 minutes. So what's wrong in that? So we know our milk flow, when it is flowing, initially it's the foremilk. Later on, the last bit only is your hind milk, which is very rich in proteins and lipids. So if the mother is each time giving just the foremilk only, the poor baby is not going to gain any weight, but will be passing urine very well. So this is also something you need to keep in mind and assess whenever you see a baby with poor weight gain, right? So now you know what to look for, what to assess, what questions to ask for when a baby comes with poor weight gain, right? So the main investigations, if you know that the baby looks healthy and you don't have any other problems in your mind, you are very sure that this is due to a feeding failure, you are not going to investigate this baby, unless of course there are other things like a jaundice, or dehydration. So you are just going to correct the breastfeeding technique, and you can add and also you can help the mother to boost her milk supply by breast massage, advising her on the correct technique, ensuring that there is a good hydration in the mother, that is 3 liters per day of fluid intake, sufficient mental and physical rest to the mother. And you can use a lactagogue such as domperidone as well, or maxolone in this situation. Remember, commercial milk powders or liquid formula or anything is not going to affect the milk supply of the mother and should not be encouraged at any given point. You can additionally provide a top-up for the baby, where the mother can be advised to express the milk into a cup, and then after sucking feeds, the mother can give the milk to the baby from the cup or a spoon, which will also augment the baby's weight gain. And then you are going to give a follow-up plan where you will be seeing the baby in 3-4 days time to assess weight gain, and if your diagnosis was correct, the baby will be putting on weight nicely. But if the baby is not putting on weight nicely, then you will have to again think about your secondary differential diagnosis, where there could be a pathology, and you might have to go ahead with second line with your investigations. The very first investigation I would order would be urine culture, because I know urinary tract infections can be hidden in a newborn baby without any symptoms but poor weight gain. So that's the most important investigation. If that is also normal, the second line investigations would be your renal functions. If you are hearing a murmurs, you can order an echocardiogram or ultrasound abdomen as the second and the third line investigations. Any questions on that scenario? Heart failure in children leads to weight loss. They don't develop edema so much. So because of the tachycardia and increased workload of the heart, they just develop, they don't gain weight. So heart failure, if at all, that happens around 2 weeks of life, when the pulmonary blood flow increases, because initially the pulmonary blood flow is much low because of the increased pulmonary pressures in the newborn baby, right? Any questions? Can I move to the next scenario? Yeah. So the second case scenario, we are now moving on to jaundice. So we have a 6-day-old baby born at 38 weeks of gestation Mother is concerned about jaundice. And again, the same scenario, 3 kilos, current weight is 2.5. Mother is O positive and baby is A positive. And you are not sure whether the baby is very active. So what are the possible causes for jaundice in this baby? What are the investigations? And how would you, what are the important aspects in the management for this baby in the first 24 hours of admission? Now, first things first, when you get a baby with jaundice, there are two things you need to assess before you do anything else. The very first thing is to assess the extent of jaundice. Now remember, any baby should not be appearing jaundice in the first 24 hours of life. It is always pathological. And afterwards, even a normal child can have a tinge of jaundice. So we assess the extent of jaundice from the extent that it is present. If it is very high, you will see it in the palms and the soles as the last thing. So if it is there in the palms and soles, we know it's a significant jaundice. And the other thing you need to ascertain is the activity level of the baby. That is because with very high bilirubin levels, they go into an encephalopathic situation where the activity could be changed. They might be having reduced feeding, lethargic, less activity, sometimes changes in the tone, and in severe cases there could be arching, and high-pitched cry and all that. So initially you might be able to catch the subtle changes in the activity of the baby if you ascertain carefully. So any jaundiced baby having, if you're suspicious about the activity, that baby should be sent to a tertiary care hospital, pediatric facilities, ASAP. Right. So if you are not concerned about the activity, you are happy, and the jaundice level is just up to maybe the chest level. Now how are you going to approach this baby? Here you don't have to panic and get the baby rushed into a hospital. So I will quickly go through the causes for jaundice which appears early. And the commonest cause is of course physiological jaundice, which appears about 25 hours later and disappears before 2 weeks of age, and the rise is very slow. It never goes up to very high levels, leading to encephalopathy. The other problem is your blood group incompatibility. Now this could be ABO incompatibility or RH incompatibility. ABO incompatibility occurs when a mother is O and the baby could be either A or B. It doesn't occur like, mother is A and baby is B or vice versa. It doesn't happen that way. It always have to be a mother who is O, positive or negative, and then you have the baby's blood group being A or B, right? And then you have the RH incompatibility, which is very simple. And then the other group is your septic baby, where they also have a very high risk of having jaundice. And again, this is where your activity level comes into play, because septic babies also, they could be very less active. And some babies are dehydrated, like in this example also there's a 500 gram weight loss. So you can see the baby is not, baby is having a significant weight loss at this stage. So this dehydration causes exaggerated physiological jaundice in any baby. So polycythemia is also another common cause of jaundice happening in the first couple of days of life. And one common cause for polycythemia in newborn babies is maternal gestational diabetes mellitus, or pre-existing even diabetes mellitus. Okay, right. Now, so you can go through the history and examine the baby and then decide on the investigations. The main investigations you want at this stage would be the serum bilirubin levels, total direct and indirect, and with the report you are going to now assess whether this baby needs treatment as such. Now, when you are using this bilirubin chart that is issued from the NHS, and remember, these are all gestation specific charts. For each gestation you can find a separate chart, so make sure you find the correct thing, because if this is a 36 week, if you plot it in the 38 week, then you are going to underestimate your bilirubin level. The next thing is you are going to use the total serum bilirubin, not the indirect bilirubin level. And the other most important thing is you have to determine the age of the baby very accurately, especially in the first 3 days of life. You can see this line is very sharp, isn't it? This line is very quite angulated and rapidly rising, and therefore you need to know the exact age of the baby when you have taken the blood for bilirubin analysis and correctly plotted there. And then if your bilirubin level is on or above the phototherapy level, you need to admit the baby. If this is slightly below, then it's generally advisable again to get the baby admitted. But let's say it's around like 2 or 3 boxes below, and you are very happy about the feeding, activity level is superb, there's no concern regarding infection, and the mother is feeding very well, then what you can do is you can advise them to come back to your practice maybe the next day morning, and you can clinically assess the baby and also repeat the serum bilirubin and see how it goes. Right, there's another question. There's no question, right? Okay. So I will quickly go through the treatment modalities we can provide for jaundice in a baby. So there are in the medical management we institute 3 main lines of treatment. First line is phototherapy. Second line is correct hydration of the baby. Third line is using specific medications such as IVIG. So if you take the phototherapy, that's the mainstay of treatment for babies with jaundice. So we can use up to about 3 lights, and also there are things called billy blankets that you can use for these type of babies. Now, so how many units that you are going to use totally depends on the severity of jaundice. For example, if your baby's levels are around the phototherapy level, just above the phototherapy level, just a single phototherapy unit would do. If it is in between 2, if it is close to exchange transfusion level or higher than that, then you have to start on triple phototherapy. Just because the baby's bilirubin level is above exchange transfusion, you are not going to rush and do an exchange transfusion in this type of babies. I'll tell you the indications for that later. And then the next thing is about the hydration. Now, hydration should preferably be oral with breast milk. But remember, you can allow the baby to come out for feeds if the bilirubin levels are safe to do so. So that means if your bilirubin levels are close to the phototherapy level, the baby can come out for breastfeeds and go back to receive the phototherapy. But if the baby's bilirubin level is very close to exchange transfusion, you are not going to interrupt the phototherapy delivery just because to give a feed to the baby. So you are going to ask the mother to express the milk and give this to the baby via a cup or a spoon or NG feeds. If that's not possible, you will have to put on a saline drip for these babies. Right. So third thing is your medications. So the indication for intravenous IVIG is hemolysis due to immune-mediated, alloimmune-mediated hemolysis. So that is basically your ABO incompatibility and RH incompatibility. You are not going to give IVIG for a septic baby or those who are having exaggerated physiological jaundice. So if your bilirubin level is going up despite giving medical therapy with hydration and phototherapy, you will have to consider giving IVIG for these babies in the hospital. So the indication for exchange transfusion, which is the last resort, is if your baby is showing you signs of encephalopathy, at any given time with high bilirubin, or if the bilirubin levels are rapidly rising despite all your medical treatment, right? Hope that's clear. Any questions on that? Prabhat, is it okay if I go through the questions then and there?
That's fine, as you wish.
Yeah. So one question is how maternal DM leads to neonatal polycythemia. It's because of the insulin effect. What is breast milk jaundice? Yeah, I'll be coming to that later. I'll be discussing about that later. When will you add a formula? No, you are not going to add a formula. Management means, I think we have discussed. Can physiological jaundice cause kernicterus? Extremely rare. I know you can find that in textbooks, but fortunately we don't see it there, right? It's extremely rare. I mean, physiological jaundice definition itself is you never get it into high level, so you can consider it as false. Yeah, I can explain the difference between breast milk jaundice and breastfeeding jaundice. I'll come to that. There's a proven benefit by phototherapy compared to, yeah, so the more the phototherapy units, more delivery of the lights. So I mean, triple phototherapy is always more beneficial than double phototherapy. Yeah, that also is included when you are suspecting. So the main, I mean, if your babe, now the first I told you, the first investigation you do is serum bilirubin level when the baby looks clinically jaundiced. That is to ascertain whether the jaundice is significant or not. So if you think the bilirubin levels are actually, high and the baby needs treatment, yes, now you have to go to the second line investigations in a ward setup, and then find the cause for it. So this includes your blood picture, looking for hemolysis, DAT, baby's blood group level, blood group, and the retic count. One common question asked by others is whether a septic screening is necessary in all babies with jaundice. The answer is no. Septic screening is indicated only if you suspect the baby is having sepsis. That's all. Otherwise, that's not necessary. Right, so after you start the treatment in this baby in the ward, you will have to now serially monitor the bilirubin levels and assess the response. So if your bilirubin levels were super high at the very beginning, you're going to repeat it in about 4 hours duration to see whether it's coming down. If it was around this point, you are going to repeat it in 6 to 8 hours time. When are you going to stop phototherapy? So the bilirubin levels should be coming down nicely, and it should come at least 5 small blocks below the phototherapy line, and then you are going to stop the phototherapy. And after that, you are going to recheck. After stopping the phototherapy for 6 hours, you are going to recheck for rebound bilirubin level, especially in babies who are having hemolysis. They can have a rebound hyperbilirubinemia when we stop the phototherapy level. So that's the initial management, right? Okay, right. So now we are moving on to this is the third case scenario, where we have again jaundice. 17-day-old baby born at term, brought to the well baby clinic with jaundice. Baby is active, gaining weight also. Now we are thinking what our differential diagnosis is and how will you manage this baby. Now this is a totally different scenario from what we discussed before. That was a very young baby with jaundice, where you are thinking about kernicterus. That's my main worry there, right? Because the bilirubin levels can go up very quickly, cross the blood-brain barrier, and cause encephalopathy initially, which can lead to kernicterus later, and leading to cerebral palsy, hearing deficits, and chorioathetoid cerebral palsy. Now, when they are a little older, we are not worried about kernicterus anymore. We know that the blood-brain barrier is now, well formed. So now the main concern is, okay, why on earth is this baby continuing to have jaundice, right? So there could be some pathology underlying this in this baby. Then that's maybe that's the reason why this baby is continuing to have jaundice. We know Beyond 14 days, you don't consider it as physiological jaundice according to the definition. So this scenario is known as prolonged jaundice, where the jaundice either starts or persists beyond 14 days in a term baby or 3 weeks in a preterm baby. So there are lots of differential diagnoses that you will have to entertain in this situation, right? So prolonged jaundice could be unconjugated as well as conjugated. Okay, so that's the very first thing you are going to ascertain, whether it's direct hyperbilirubinemia or indirect hyperbilirubinemia. So how do you do that? You just ask from the history, what is the stool color? So you get this stool color in the chart. So if it is conjugated hyperbilirubinemia, you get these 3 stool colors. If it is unconjugated, these 3 pigmented colors. And the urine will be dark in conjugated and pale in unconjugated. And the baby will be deeply icteric in direct or conjugated, and not deeply icteric in indirect hyperbilirubinemia. So I'm going to first go through the causes for indirect hyperbilirubinemia. Most commonly, it is due to breast milk jaundice, but it could also be due to continuation of hemolysis, urinary tract infections, congenital infections, or hypothyroidism. The direct hyperbilirubinemia is always pathological, where you are thinking about biliary atresia, neonatal hepatitis syndrome, and sometimes hypothyroidism can cause both indirect and direct hyperbilirubinemia. Now I'm coming to these conditions. So hemolysis it's generally because of either a red cell membrane disorder such as spherocytosis or glucose 6-phosphate dehydrogenase deficiency, very rarely due to ABO incompatibility. Urinary tract infections, we already know, that is the commonest infection that causes indirect hyperbilirubinemia. The baby might stay, asymptomatic without any dysuria or anything, but having prolonged jaundice. Hypothyroidism, we will be discussing about that later, and we are screening each baby for hypothyroidism as well. Now I'm coming to the breast milk jaundice, and there was a question also related to this. Breast milk jaundice is, not a pathological phenomenon that is due to a certain constituent in the breast milk, which is unconjugating the conjugated bilirubin which enters the gut. Okay, so now if you remember the bilirubin pathway, bilirubin is made into conjugated bilirubin in the liver, and this conjugated bilirubin is excreted in the bile into the gut. So what happens is, due to this constituent in the breast milk, this conjugated bilirubin is again converted into unconjugated. So what happens is, this unconjugated fraction keeps on getting absorbed into the system. Therefore, the baby continues to have jaundice. Simple as that. So you see, these babies, this is a diagnosis of exclusion. But these babies should necessarily be having a very good weight gain. Their examination should otherwise be normal, apart from having a tinge of jaundice. So those are the main characteristics. And the breast milk jaundice should disappear by 8 to 12 weeks of life. Okay, but due to any other causes, they will be having any additional features. For example, if it is due to hemolysis, the babies will look pale, they can have splenomegaly, they can have a family history as well. Urinary tract infections, we know. Hypothyroidism, we know. Congenital infection, we know what to ask for. Okay, so direct, of course, we have already discussed. And the question was, what is the difference between breast milk jaundice and breastfeeding jaundice? So it's very simple to remember. If you just look at the name, breast milk jaundice is due to a constituent in the milk. Breastfeeding jaundice is due to a problem with the feeding technique. So that means due to inefficient feeding, baby is getting dehydrated, leading to starvation jaundice or exaggerated physiological jaundice. Okay, so breastfeeding jaundice therefore happens in the early phase, in the first couple of days of life. Breast milk jaundice is actually, now remember, if that constituent to cause bilirubin unconjugation and prolongation of jaundice, baby must be drinking lot of milk also, no? So that means breast milk jaundice happens only later, and that's the cause for prolonged jaundice only. We are not going to consider this in the early stage, right? I hope that's clear. Okay, so if we go back to our patient now, 17-day term, birth weight is nice, so unlikely to be having congenital infections or anything. Nicely putting on weight. Now you have examined, perfectly normal, healthy, active, no pallor, no splenomegaly, no hepatomegaly. Baby is completely normal. So your most likely diagnosis at this stage would be your breast milk jaundice. But make sure you do a bilirubin level, serum bilirubin level with total direct and indirect, just for you to be sure that you are not missing a conjugated hyperbilirubinemia, because that's a shame if we miss it. Because if we miss a conjugated hyperbilirubinemia and the baby turns out to be having biliary atresia, that's the end of the story, because we know all the biliary atresia babies should be identified and referred to the pediatric surgeon, and the surgery must be done, that's a Kasai procedure, must be done before 6 weeks of age for you to get good results. So it's a shame if we miss it. So if you ever see a baby having jaundice beyond 2 weeks of life, you are expected to do your fractionated bilirubin levels. And that, remember, you call it conjugated hyperbilirubinemia if your conjugated fraction is, give me a second. Hello? Hello? Yeah. 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 Oh, okay. Thank you. Okay. Okay, thank you. All right. Okay. So that is about that. So we were at conjugated hyperbilirubinemia. How we diagnose conjugated hyperbilirubinemia is from the total fraction, from the total level. If your conjugated bilirubin is more than 20%, you consider it as conjugated hyperbilirubinemia. Okay, it's not like conjugated is more than unconjugated. No, nothing like that. You go by the fraction of it, right? Neonatal hypothermia. So any questions on the prolonged jaundice, breast milk jaundice and all that? I think we can rush through this neonatal hypothermia. That's very common, and I think you guys know this. Because I only have 15 more minutes. Okay, so now newborn sepsis. So why I want to talk about newborn sepsis is, remember, neonatal sepsis is the main killer in our country. 1/3 of babies who die as newborns, they die due to newborn sepsis. So it is sometimes difficult for you to identify, but we need to know about this, right? So newborn sepsis is commonly due to group B streptococcal infection, even in our country, and they can present even up to 3 months of age with group B streptococcal infection. Other common pathogens include gram-negative organisms such as E. coli and also Klebsiella. In the ICU setup, you can get the coagulase negative staph, as well as various fungi infections and various other gram-negative infections as well. But in the community level, you will encounter mainly the group B streptococcus, which could be coming from the mother or from the community, or gram-negative organisms, which could come from the community. Right. So neonatal sepsis mainly presents in 2 presentations. One is when they come present early, that is within the first 72 hours of life. Then we call it early neonatal sepsis. After the first 72 hours of life, we call it late onset newborn sepsis. So this distinction is just for us to know how the baby acquired the infection. So it's obvious now if they are getting the infection very early in their life, within the first 72 hours. So that means the mother has given the infection, isn't it? But after that, it's either from the community, or if the baby is still in the hospital, from the hospital acquired. Right. So in early onset newborn sepsis, these are the risk factors that predisposes baby to get newborn sepsis. Mama is having an infection like fever, chorioamnionitis. She has ruptured her membranes more than 18 hours, and or she went into a spontaneous preterm delivery. Mother has UTI during the last trimester, or mother is a GBS carrier, or mom had a previous baby who was infected invasively with GBS infection. So all these things are risk factors for early onset sepsis. Late onset sepsis is generally, if coming from the community, it is due to poor hygiene and lot of handling in the newborn in overcrowded situations. In the hospital scenario, commonly this happens to babies who are admitted to NICUs, where there is a lot of intervention and also usage of antibiotics. Right. Whatever it is, it could be early onset sepsis or late onset sepsis. The features are common and they are very, very non-specific. They commonly present with reduced activity, reduced feeding, hypothermia. They become cold rather than having fever. So that's a very important thing you need to remember. They don't commonly come with fever when they are having an infection. Rather, they would come with low body temperature, that is less than 36.5. They can have tachycardia, any heart rate more than 160 in a term baby or 180 in a preterm. We are talking about very high rates actually. It's known as tachycardia. Respiratory distress, right? Severe jaundice, we discussed about this. Having low sugars or jitteriness, excessive jitteriness. Umbilical sepsis, okay, not moving the body, we call it not moving arms, we call it pseudoparalysis of arms or limbs. These all can indicate neonatal sepsis. So what do you do? If you have, now remember, if you have a suspicion of sepsis in a newborn baby, you are not going to confirm the diagnosis and treat the baby. So this is little different from an adult. In an adult or a big child, we would do specific investigations. We would send a full blood count, we would send a CRP, and then we would like to wait and look at the lab reports, confirm our diagnosis, and then start antibiotics. But remember, I'm going to emphasize again, in newborn babies, you are not going to waste a single minute. If you are suspicious, you don't have to confirm your diagnosis of sepsis. You can straight away do a partial septic screening and start on antibiotics. Partial septic screening means full blood count, CRP, and a blood culture. In late onset sepsis, that is after the 72 hours of life, you have to do a urine culture as well. Some situations you will need a lumbar puncture, but that's later in the hospital, definitely not as outpatient. So what is the treatment? You need to start intravenous antibiotics. There's no place for oral antibiotics. So the first line would be benzyl penicillin together with gentamicin. If you are suspicious that the baby is having meningitis, you can always give cefotaxime instead of giving gentamicin because you're worried about the blood-brain barrier penetration of gentamicin. We always give this combination because we know benzyl penicillin is universally going to destroy your group B streptococcal bacteria, which is the commonest pathogen in newborn sepsis. And why we can combine this with gentamicin is one is to cover the gram negatives and also to obtain the synergistic effect against GBS when you combine benzyl penicillin together with gentamicin. When it comes to cephalosporins, we only use third generation cephalosporins. There's no place for second generation like cefuroxime. And also in the third generation also, you can only use cefotaxime. We should not be using ceftriaxone because there could be serious side effects of ceftriaxone in newborn babies, right? Okay, now we are moving on to another thing, that is the seizure. Now you can see in this video. So this is obvious, this baby is having generalized, these are chronic movements, right? These are chronic movements. But there could be other presentations too. There could be other presentations too. So most of the seizures, remember, they are subtle. So that means just a lip smacking. They are looking at one side, being unresponsive, being hypotonic. That is your subtle seizure. Sometimes you see that type of a clonic seizure. Sometimes a tonic seizure where the baby maintains a rigid posture. Sometimes it's like a myoclonus, right, where there are very jerky like movements in the baby's body. So those are the main types of seizures that you can find in newborn babies. So there are a lot of causes for seizures, which includes the commonest cause is hypoglycemia, and you can have electrolyte abnormalities like hyponatremia, calcium problems, hypocalcemia, hypomagnesemia, those things, and also meningitis, right? And also rarely some other syndromic problems could also be there. So management, you have to always refer these patients to a tertiary care center where we will go through the investigations. And the first line anti-epileptic in newborn seizures would be phenobarbital, not midazolam, right? Okay, now look at this video. What can you see? You can see this baby is tachypnic. Tachypnic in a newborn baby means respiratory rate more than 60 per minute. You can see subcostal recessions, okay? You might be able to see some intercostal recessions over there. So the other features to look for will be grunting, nasal flaring. So those features indicate respiratory distress. Again, a sign of sepsis, and the baby should be referred to the tertiary care unit, right? Okay. Questions? Can we use vigabatrin? No place for vigabatrin in newborns. Right. So fever. Fever could also be a presentation in newborns to your practice. Now fever means any temperature more than 37.5 in a newborn, right? So there are two conditions that you are going to entertain when a baby is presenting with fever. One is of course sepsis. The other one is dehydration fever. I just included this slide just to emphasize that there is a thing called dehydration fever in newborns. So you can very carefully make this diagnosis by looking at the baby. The baby look dehydrated, and mainly there will be a significant weight loss by the time you are seeing this baby. Right, now we have come to the end of our lecture. So I will play this video. This is a newborn examination video.
In this video, we'll demonstrate how to perform a routine newborn examination. It must be a head-to-toe examination, but it's all right to start with auscultation first if the baby appears quite settled. But make sure your hands are clean and dry as well as warm. And make sure your stethoscope is warm as well. As this baby is nicely settled, I'm going to start my examination with auscultation of the heart. Next, I'll move on to auscultation of the lungs. inspection of the baby. How does the baby appear? What is the general well-being of the baby? Is the baby active or lethargic? What is the color of the baby? Does the baby appear pink or does the baby appear jaundiced? If the baby starts crying, you can always try to settle the baby by giving him his own thumb or one of the fingers and allow to suck, as shown in this video. You can see that this baby is having a nice color and having a nice sucking, and also baby is pink. Look at baby's face to see. Next, palpate the scalp. First, palpate the anterior fontanelle. It should be soft and not bulging and should measure 2 finger breadths in each direction. Go along the suture to palpate the posterior fontanelle. Also palpate the scalp to see if there are any lumps. These lumps could be cephal hematomas, which will be present on the either side of the head if they are present. A caput, which would be palpable at the vertex, and also rarely there could be a subgaleal hematoma. Eye examination must include looking for red reflex. As the baby is now keeping the eyes closed, we will keep to the end of our examination. Examine the ears. See if the ears are well formed. Look for any sinuses or any skin tags anterior to the ear. Examine both ears. Examination of the mouth must include any presence of teeth, which could be neonatal teeth, and also look for evidence of a tongue tie. And when the baby is crying, we must always examine the palate to see if there is a cleft palate. This can be further determined by palpation of the palate, which I'll show you towards the end of the examination. Okay. Next, palpate the sternocleidomastoid muscle to see if there are any lumps, which could be a sternocleidomastoid tumor. And then palpate the clavicles, looking for evidence of fractures. Clavicle fracture is the commonest fracture seen in the newborn. Examine the limbs to see whether the limb length is all right, and then check the fingers. Count the number of fingers to see whether there are 5 fingers. Open the palm gently to look for creases, palm creases. Examination of the chest. Look for any chest wall deformities, such as pectus excavator or pectus carinator. Look at the nipples. In some babies, there could be a slight enlargement of the breasts, which is physiological. Look for any evidence of respiratory distress, which could present as intercostal recessions, subcostal recessions, or suprasternal recessions. That's okay. Moving on to the examination of the abdomen. Look if the abdomen looks distended. Check whether the umbilicus appears healthy. Are there any discharges or redness around the umbilicus? Then gently palpate the abdomen to look for hepatomegaly, splenomegaly, and look for palatable masses. Next, check for femoral pulses in the groin. Make sure you don't apply too much pressure when you are palpating for femoral pulses. They should be nicely felt in good volume. If the volume is less, or if you can't feel the femoral pulses, this could indicate the coarctation of aorta. Move on to examine the genitalia of the baby. In a male baby, examine the scrotum and palpate the testicles. Check whether they are of normal size. Rarely, there could be either an inguinal hernia or a hydrocele, which could be palpated. Examine the penis, check for curvature, and also the presence of the urethral opening at the tip of the penis. And then we'll move on to examine the anus. Inspect for the patency of the anus. If that is not seen, that is due to imperforate anus. Then examine the baby's lower limbs. Again, see if they are symmetrical. Look for any abnormal shape.
Recording
And
in
then,
progress.
also look for evidence of any leg deformities, calicles. Put the baby prone to inspect the back. See if you can see any deformities along the spine. In spinal dystrophism, there could be some pits or a tuft of hair or a pigmentation around the spinal area. Painful procedures like hip examination, examination of the palate, and checking for anthropometry should be left to the last. Now we will check for the hip. We are examining the hip to see if there is any evidence of developmental dysplasia of the hip. There are two maneuvers that we would like to perform. First one is Barlow's maneuver, where we check whether the hip is dislocatable, and next we will check the Ortolani maneuver to check if the hip can be relocated. I will now demonstrate the Barlow's technique. Keep the baby's hips and knees flexed at 90 degrees. Keep your thumbs at the medial aspect of the thigh while keeping the fingers over the greater trochanter, as shown here. The idea is to adapt the hip slightly, and next we push down the hip posteriorly to see if we can dislocate the hip. This will be felt as a clunk. We need to check both sides. Next, we will go on to check for Ortolani maneuver. There, again we are keeping the hips flexed like this, while keeping the thumbs over the groin crease and keeping the fingers over the greater trochanter. And here we will try to abduct the hip while applying pressure posteriorly, trying to move the femoral head upwards. As it is a painful procedure, usually baby cries during this maneuver. Anthropometric measures include checking the OFC, weight and length of the baby. To check the OFC, we need an assistant. This is checked from the most prominent part of the skull, which is the occiput posteriorly, and the most prominent part of the forehead, as shown in this video. And you measure the OFC of the baby. Next, we will check for neonatal reflexes. Look for sucking reflex. Check for the palmar grasp. And next, we'll check for the Moro reflex. To see the Moro reflex, we need to hold the baby in the seated position, slightly upright position, and then we'll drop the baby by about 1 to 2 inches to my own hand. I'll do it again. There. Baby opens the eyes, check for the lid reflex. Check the palate by palpating the palate with a gloved finger. Look for any defects that you can feel posteriorly.
All right, so now we have gone through the newborn examination. Let's quickly go through what abnormalities you can detect. So what is this? This is a cephal hematoma. You get this in parietal aspect. The main thing is this is very firm and it does not cross the suture lines. Okay. So this is going to stay there for some time, couple of months. You just have to reassure the mother. The only complication it can cause is prolonged jaundice. Apart from that, no other complications. So this is a very common rash that you encounter. Most of the mothers get super excited about this, but this is called erythema toxicum. You can see the reddish patches which is there in the face as well as the
Hello, excuse me.
yeah.
Can you keep the mic closer a bit?
All right, okay. Is it better now?
Yeah,
Yeah,
sure.
okay. So again, just the reassurance is the only thing which is necessary. This will resolve on its own. So these are pustular melanosis of the newborn. Again, a normal phenomenon. You should not be giving any antibiotics or local application. Just regular bathing is sufficient. This is also going to go away. So you can see a vaginal discharge in newborn female babies. It's like the period they get a withdrawal bleed. That is because when the maternal estrogen levels which has been passed to the baby, it's already not which is not there. They are going to have this withdrawal bleeding, which is again normal. You are not going to just reassure, we are not going to investigate or do anything about it. And the other thing is there could be a pinkish stain in the urine of the babies. This is called as urate crystals. Again, a normal phenomenon, not associated with dehydration, just the reassurance only. So you can see that this is an umbilicus. You can see a little cherry-like polyp which is coming out of the umbilicus. This is called an umbilical granuloma. Now this can cause some discharge, foul-smelling discharge sometimes, and also intermittent bleeding. Again, a concern for the parents, but just reassure, this is generally going to go down on its own. But if there's a significant bleeding or parental anxiety, or if it is persisting beyond 1 month, then it is advisable to cauterize just by applying some copper sulfate over this, and you are just going to cauterize it and quickly remove the copper sulfate and clean the area to make sure there is no chemical burn due to copper sulfate. Now you can see that the in a male baby you can see the scrotum is swollen. So this can happen commonly due to two causes mainly. One is hydrocele, the other one is inguinal hernia. Now it's very important to differentiate inguinal hernia from hydrocele in a newborn baby, because we know if it is hydrocele, you don't have to do anything about it. You just watch and wait, that is going to resolve. But if it is an inguinal hernia, this baby needs referral to a pediatric surgeon as soon as possible. I mean, not as a casualty admission. The baby can be referred on discharge to the pediatric surgeon, because unlike in adults, the inguinal hernias in newborn babies, that is more prone to get obstructed and strangulated. Therefore, these cases must be operated in the next available list. So how are you going to differentiate from inguinal hernia and hydrocele? Again, simple. You use the same techniques you use in an adult. So the inguinal hernia, you can't get above the lump, but hydrocele you can. And the other thing is, of course, the transillumination, where there will be transillumination in the hydrocele and not so in the inguinal hernia. So this is again a common limb deformity that we see. This is a talipes in babies. So talipes could be of two varieties. One is physiological and the other one is fixed and pathological. In the physiological variation, you can always maneuver the baby's foot into the normal position just by yourself, and this does not cause any pain to the baby. So those type of babies, you leave them alone, you don't do anything about it. But if it is fixed, these babies needs to be referred to the orthopedic surgeons as early as possible, because they are going to start the POP plasters and they are going to start the reduction of this as soon as possible. So you can see that this is a hypospadia. There is an abnormal curvature of the penis, and especially along with a hooded prepuce, and you can see the opening of the urethra is not situated at the end of the penis, but rather somewhere in the corona or in the shaft of the penis, or sometimes maybe in the perineum like in this picture. So this is hypospadias. Again, you don't have to do anything urgent about these babies. They can be discharged after they pass urine, and can be revived and later on referred to the pediatric surgeon. But it's extremely important to educate the parent that they cannot have circumcision, because the foreskin is going to be used to repair this anomaly. Therefore, circumcision is prohibited in this situation. That's the only thing you need to remember, right? Now going for the hip, the developmental dysplasia of the hip, you have already seen how to assess the baby clinically. So if there is a DDH, you will feel a clunk when you are doing the hip examination. And also when you place the baby's hips like this, you can appreciate sometimes there is a discrepancy between the length of the femur. So this is a significant clinical feature. And if you look at these pictures, you can see there is an asymmetry in the skin folds of the buttock and the thigh. So all these clinical features suggest developmental dysplasia of the hip. If you find this is the case, these babies need an early referral to the orthopedic surgeons, where they will arrange the ultrasound scan and also treatment with Pavlik harness in the first 6 months of life. After that, they will have to do the closed reduction, failing which they will have to go for open reduction. There are certain situations where we have to screen for DDH, although there are no clinical features. The main two indication for you to screen with an ultrasound scan of hip at 4 weeks of life, not soon after birth, from 4 to 6 weeks of life, is when the babies are presenting in the breech presentation. And the other indication is when they are having a significant lower limb anatomical problem like a fixed talipes. In that situation also, routinely you have to order an ultrasound scan of the hip around 4 to 6 weeks of life, right? Congenital hypothyroidism, I thought I will talk a few words about this. So that is, 1 in 4,000 babies can have congenital hypothyroidism. Why this is important is this is the main cause of mental retardation that is preventable and treatable. So therefore, it's extremely important. We screen all the babies for congenital hypothyroidism with the heel prick. And if the result is abnormal only, they will be notified. The MOH office is notified from the laboratory, either MRI or from the Karapitiya laboratory, and they will come to you with the report. So how are you going to go? Now, congenital hypothyroidism is almost all the time due to agenesis or hypergenesis of the thyroid gland. It's not due to the disruption of the hormone synthesis or autoimmune like you see in adults. So they don't have the gland in the proper way, right? So that is why we screen them with TSH, which should be invariably high in these situations, right? So just remember, if the TSH concentration is high between 20 to 40, more than 20, what you do is you just repeat a venous blood sample with TSH together with free T4 then and there. If you can get the results on the same day, you are going to wait. If the results are going to be delayed, you are going to start treatment, because even a single day delay can cause a significant impairment in the IQ of the baby, right? So now you receive the venous blood sample. If the free T4 concentration is below the normal range, irrespective of the TSH, you have to start treatment immediately. So that's the first thing. And also, if the venous TSH concentration is more than 20, even if the free T4 is normal, again you have to start the treatment. But then there's a gray area where the TSH is between 6 to 20 in a well baby with normal free T4. For them, you are going to watch and wait. But first of all, you are going to perform all these babies with congenital hypothyroidism needs an ultrasound scan of the thyroid. But in this, gray area, what you do is you perform an ultrasound scan of the thyroid. If that is normal, you will not start treatment, but you will be repeating the thyroid function test every second week. But in the scan, if they say the thyroid gland is dysgenetic, it's not formed well, then you know that it's not going to be functioning well. So you will have to start treatment. Now the treatment is with levothyroxine. Unfortunately, we don't have the syrup, so it will again be the tablet, which should be dissolved in either water or breast milk, and the mother should be advised that it should be given daily around 8 o'clock in the morning on empty stomach. So the baby should be fed only after 30 to 45 minutes after giving the medication. And we need to serially monitor the TSH and the free T4 levels as well. Once you have started them on the doses, initial dose 10 to 15 mics per kg. Once you start the treatment, you have to repeat the TSH and T4 levels in 2 weeks time to see the response. Once you have got the baby into the normal levels, in the first six months of life, you are supposed to monitor the levels every 6 weeks, and after that every 8 weeks, and after that in the second and third years of life we are not going to frequently assess this, but like 6 monthly and later on annually. So that is how we are going to manage congenital hypothyroidism. It's extremely important to talk to the parents and emphasize this, that this has to be taken every day, and if you don't get it, then the baby can get problems with the IQ. So that's extremely important. Okay, so I'm just going to go through this, how to identify abnormal sacral pit. Now a sacral pit will be considered abnormal if you can't find the bottom of it, right? If you can't see the total length of it, you can't ascertain where the sacral pit is going, that's abnormal, and you need to order an ultrasound scan of the spine to look for the extension of the sacral pit. Okay, that's all I have for you today. So if there are any further questions, I'm happy to answer.
Madam, there are a few questions in the chat box. Shall I read it to you?
Yeah.
Um, One is regarding the neonatal examination and maturity assessment, whether it's the
No,
same.
these are two things. Maturity assessment you don't do in a term baby. This is especially useful in premature babies, and when mothers come without knowing their gestation, like they couldn't get the scan done, all of a sudden they come and deliver the baby. For that we use this. There's a specific chart for you to use, and it's a long process using these charts. It's a different thing. It's totally different.
The next one, it's about neonatal meningitis, the duration of IV antibiotics. Is
So
it
total of, if it is group B streptococcus, the total of 14 days is enough. If you don't know the cause, the organism, or if it is gram negative, you have to give for 21 days. When you are giving 21 days, you should complete it. Cefotaxime should be given for 21 days, and you stop penicillin at 14 days.
there's another one regarding indirect hyperbilirubinemia. How UTI lead to that?
That's because of cytokine release, and that affects the bilirubin metabolism in the liver.
And then how many hours after we should do the bilirubin level? Like how many hours after stopping phototherapy we
After
have to do
starting
the
or stopping? Stopping.
stopping? Yes.
Yes, after 6 hours. You stop it. In 6 hours time, you are checking for rebound bilirubin levels.
And then, how maternal diabetes lead to neonatal polycythemia?
Yeah, insulin effect. I think we discussed about this. Yeah.
Then Uh, management of bulging of fontanelle after vitamin A dose.
Vitamin A dose, bulging of fontanelle, you don't do anything, just reassuring only.
Okay.
Nothing to be done. Yeah.
What is BCG lymphadenitis?
So that is an abnormal reaction to the BCG. You get some lymph nodes, but in the axillary region. Generally, you just watch and wait. It doesn't cause any trouble. But if it is persisting, you will have to refer the child to a pediatric pulmonologist and go for the further evaluation and management.
And then there's another question about umbilical granuloma. How long we are going to observe after cauterization?
So it's like this. Ideally, how you should cauterize it, you should be keeping that copper sulfate thing on the granuloma and make sure it is getting dried off. So it takes couple of minutes, but I have seen some practitioners, they just apply it and send the baby home, which must be discouraged because that can cause some chemical burning into the skin. So it should be done, you have to keep it there and cauterize it and then clean it and send the baby home without, sending the baby with that copper sulfate on the skin. Okay.
Okay. Madam, there's another one regarding vitamin A megadose, whether it's contraindicated after anterior fontanelle bulging.
Generally, we don't give it again. Yeah.
Um, yeah, uh, that's about it.
Okay. Good.
Yes, ma'am.
Good. Okay.
Thank you very much, madam.
All right. Thank you. Good night. Yeah.
Thank you, madam. And I want to ask everyone to fill the form, and I want to thank everyone for joining us today. So I'll give a heads up on our next CPD event. It will be a midday session, which will be held on the 10th of September from 12 noon onwards. And it will cover an update on primary care aspects of issues on sexuality. Thank you very much, madam, for sharing your
Okay.
expertise
Bye.
and
Welcome.
spending your time on us.
Okay. Thank you
We'll
for
wrap
having
up
me.
today.
Good night, everyone. Okay. Bye.
Good night.